And we're pleased to have you join us today for our epilepsy expert webinar featuring Dr. Garnett Smith. Dr. Smith is a pediatric epileptologist and the director of our pediatric epilepsy surgery and neuromodulation program. Our presentation today will be on neuromodulation and epilepsy, looking at the past, the present, and the future. So, Dr. Smith, I will hand it off to you.
Thanks, Russ. Yeah, it's a pleasure to be here. One of the things I love about my job is just the chance to share information and help families and caregivers and patients make the most informed decisions they can. So I really appreciate this format, and I'm really grateful to be here. I hope that if questions arise during the discussion, during the presentation, we can have a good discussion. I've left a little bit of time at the end for that, so hopefully that works. What I thought I would do, well, first of all, I don't have any financial disclosures or conflicts of interest to disclose. But in discussing these neuromodulatory therapies, especially in the context of treating pediatric patients, we often discuss treatments that are off-label, that haven't been formally approved by the FDA. So that's something to keep in mind. But my main goal here is really to talk about neuromodulation, but I think we should lay a little bit of groundwork. It's probably something that many of you are already familiar with, so I won't spend a lot of time on it. But this is a graphic that we often show in presentations like this, where the rate of drug development has accelerated over the last 15, 20 years. And neuromodulatory therapies are a very recent sort of variable in this equation, but they can have important application and for some patients, very, very good benefit. So it's worth talking about that. Of course, neuromodulation usually is mentioned and discussed in the broader context of surgery to treat epilepsy. And when we're talking about surgery to treat epilepsy in all of its various forms, it's helpful to keep in mind, how effective our anti-seizure medications are. And this is one part of the total efficacy equation. So, what proportion of patients become seizure-free, after our first medication, after our second medication, after our third. But the other side of this coin is quality of life, right? We often are in these discussions about what are the side effects? What are the unanticipated effects of the medications we're using? How does that balance with the number of seizures we're seeing? And should we be thinking harder about alternative therapies like the ketogenic diet or surgery, right? So it comes up in that context as well. Of course, our goal with any of our treatments is seizure freedom without side effects, but that's not always possible. So we often have to have discussions about, is it worth trying to increase meds, maybe exposing someone to more side effects with the potential to improve seizure frequency, but with also the potential to cause issues with quality of life or things like that. How do we determine if surgery is an option? Location is a very important part of this equation, right? This is just a kind of the funny cartoon, but it really does apply to most people. That the different parts of our brain are sort of mapped to these different functions, right? And if we can identify exactly where seizures are coming from, we can have a very good idea about what function might be affected by a surgery to create a scar or to take out a small piece of brain in that area. And sometimes we arrive at this point where we know where seizures are coming from, but the potential harm from doing a surgery where we resect or take out a piece of brain tissue or create a scar there's too much risk for causing a meaningful injury that would be intolerable. And so even when we have focal seizures that are easy to localize, sometimes we arrive at neuromodulation as an option because it has the potential to improve seizures without causing this sort of injury that we sometimes worry about. So there's a whole process, and many of you will probably be familiar with this process. We obtain the history. We talk about what seizures look like because that can give us a very good idea about where they might be coming from. The word we use is semiology. You might have heard that word before. Are they truly refractory to medication? Meaning, have we truly given a patient at least two medications at therapeutic doses? They were tolerated well enough to continue for some period of time, and they're still having seizures. We try to capture seizures on EEG. Phase one monitoring is where we bring a patient into the hospital. We connect them to EEG. We wean medications usually to try to capture typical events in an effort to really get a good picture of where these are coming from. Of course, we have to capture seizures. I apologize for how light this text is. To really make that a meaningful endeavor. But we can also get a good idea of what's going on in between seizures during those phase one trials. And then there are all of these other things that we do to shore up our thinking and to add additional evidence to support our thinking and our hypothesis about where seizures might be coming from. Imaging of the brain with MRI. There's this class of imaging called functional imaging, where we do functional MRI, PET, where we inject a tracer in between seizures. SPECT is where we inject at the time of seizure, and the radio-labeled tracer is taken up more actively, more avidly by the parts of the brain that produce seizure. And MEG, which is a way of measuring the magnetic fields generated by the electricity that the brain produces. So ancillary studies, we can do something called a WADA test to help to localize memory and language function in someone's brain. And then we have these experts in other fields, social work and neuropsychology, speech and language pathology, who can help us understand where relative strengths and weaknesses are, and also which areas of the brain may be affected by the seizures and by the underlying cause of the epilepsy. Of course, we present all of this information, and we come up with a consensus about what we're going to recommend and what we feel like we can offer. There's another sort of important distinction we try to make during this process because it affects how we approach treatment, and that is that the distinction between generalized and focal epilepsy, or generalized seizures and focal seizures. This is just an example of a generalized seizure where when the seizure starts, here in the third second on the page of this EEG, the whole brain looks like it's producing the seizure at once. The spikes are present everywhere. That has important implications for where seizures are coming from and how we treat. And a focal seizure, which might start much more subtly in a small area of the brain and then spread eventually to involve the whole brain, but it starts in a small focal area. And historically, focal seizures are the seizures that have been more amenable to surgical treatments. We have an increasing number of surgical treatments for generalized epilepsy. And that's something we often talk about with patients. Neuromodulatory therapies, which we'll talk about, of course, in more detail, are increasingly used and more available for generalized epilepsy as well. Resection, like we've talked about. Have we identified an area of the brain that's producing seizures that if we were to take it out or create a scar there would not cause an injury, an intolerable injury to the patient? If so, then resection is probably the best option because it definitely has the greatest chance of bringing about complete freedom from seizures. It's important to remember that if we say seizure freedom, we don't always mean free of seizures and off all medications. That is something that can happen. The more common situation in seizure freedom is still on some sort of medication, but hopefully on lower doses and on a combination that isn't causing side effects. Long-term seizure freedom also depends on exactly what part of the brain seizures are coming from. This has implications for neuromodulatory therapy as well. The area of the brain with the best evidence for and highest chance of seizure freedom is the temporal lobe, especially if that's what we call the non-dominant temporal lobe. For most of us, that's the right temporal lobe, because language and memory function are mostly controlled and found in the left temporal lobe. But that's part of why we do all this testing, is to make sure we know exactly which side which temporal lobe is predominant in those functions. As you can see, if you go outside of the temporal lobe, especially in the frontal lobe, which is just a very large area in the human brain, it can be a little bit harder to find where those seizures are. They're often highly interconnected among brain regions and across the hemispheres. So frontal lobe seizures are a little bit harder to bring about seizure freedom. In pediatric patients, the numbers are largely parallel. I think because our patients tend to be younger and they haven't had epilepsy as long, if they have resective surgery, our outcomes are better than in the adult population. Kids are special that way. They're a little bit more flexible and resilient, if we take a piece of brain out. And sometimes we're able to get away with larger resections because we know that kids will recover better than adults from those surgeries. So that's sort of the groundwork for sort of our classic thinking and evaluation and methodology for surgery to treat epilepsy. Of course, we're here to talk about neuromodulatory therapies today. And the three main neuromodulation methodologies are responsive neurostimulation, deep brain stimulation, and vagal nerve stimulation. We'll talk more in detail about these three, but these are terms to know, and we often refer to them by these acronyms RNS, DBS, and VNS when we talk to patients, when we talk to each other about this. So the first is RNS. So we'll talk about RNS, responsive neurostimulation. I like this illustration because it gives you a good sense of the scale of the actual hardware and the fact that in contrast to the other technologies, the stimulator and battery is implanted directly in the skull. The neurosurgeon actually excavates a piece of the skull, puts a metal, they call it a pan, sort of in that area of skull, and then they can clip the device in that has the processor and the electrical circuitry to manage the monitoring and stimulation as well as the battery. And then we have options. So what's illustrated here is sort of the options that we have. So this is called a strip electrode, where it sort of sits on the surface of the brain. And this is what's called a depth electrode, where we sort of push it through the brain tissue to the exact right spot that we want it to be in. We can implant up to 4 of these electrodes, but as you can see, and is nicely illustrated here, we can only connect 2 at a time. Here at University of Michigan, what we tend to do is identify the 2 spots that we think will be most helpful. We identify 2 additional locations that we think are involved early in seizure or that may be helpful to stimulate from. And then, at the time of implant, we connect these 2, and if further down the line we start to think maybe we should switch, that option is available. It is a surgery involving a skin incision, but it's the extra electrode, the wires are coiled very close, so that it's a matter of the surgeon unplugging and plugging in and then closing the skin incision. It doesn't require new holes through the skull or new incisions through the bone. So that's what it looks like sort of practically and technologically. One of the big advantages of responsive neurostimulation is this device continuously monitors brain activity from the regions where the connected electrodes are located. And then it uses seizure detection algorithms to detect what we program it to detect, and then to deliver some electrical energy to the brain tissue when it sees what we've trained it to respond to. In some patients, and I think this is an important thing to mention, in some patients that is seizures, but not in everyone. In fact, what we've learned over the years of treating with RNS is that if we only were to stimulate on seizures, which hopefully are a relatively rare occurrence, patients don't do quite as well as if we provide between 500 and 2,000 stimulations every day. That might seem like a huge number, but with RNS, each stimulation lasts a fraction of a second. So a patient might receive 2 to 3 minutes of stimulation from the device over the course of a day. But the advantage and the theory here is that we're applying that stimulation during a time when the brain circuits are doing something abnormal that is associated with seizure or produces seizure. And we're hopefully training those connected brain regions, those brain circuits, to behave differently. And hopefully that different behavior is a reduction in seizures. The other advantage here is that as it records and stimulates, it can capture data that we ask it to capture. Usually what it captures is what we call long episodes, periods where the seizure pattern persists for a number of seconds, which is likely to be a seizure. It will stop and store those EEG data that looks just like this, so that we can go back and look at it together and say, yes, this is a seizure. Yes, the device caught the seizure very early and delivered appropriate therapy. Or this looks like it is a seizure, but we could tweak parameters and we could deliver effective therapy more effectively by doing it earlier or on a different channel. So we learn as we go from the device, and we change our programming settings, and we hopefully get better and better treatments that are more targeted, that are delivered as early as possible after the signs of a seizure appear, and hopefully that leads to improvement over time. There's an important concept in neuromodulatory therapy about just chronic stimulation. So applying energy to these brain circuits over months and even years has a benefit. And that's even in therapies that aren't targeted to the specific brain regions that produce seizures, which is part of why we aim to deliver, between 500 and a couple thousand treatments a day. We'll talk about how the parameters look a little bit different in the other two technologies, but they're similar. All three are similar in this way, that providing stimulation at many times over the course of the day for months and years leads to long-term benefit for patients. We'll talk a little bit more about exactly what that benefit looks like and how we measure that as well. But one takeaway from this, and probably the most important takeaway from the patient perspective, is that responsive neurostimulation provides this feedback with EEG that is stored in the cloud that clinicians can access anytime. So it often happens, right? I have a family perhaps that calls and says, our child had this event. We're not sure what it was. We think it might have been a seizure. Can you take a look at what the RNS is showing us? And we can learn together with the family what's seizure, what's not, if that's the question. And we can also train the device, train ourselves, right, and program the device accordingly. So advantages of RNS: detailed feedback about the exact time and EEG features of seizures. That's a huge advantage with this system. We learn together, the device, the clinicians and patients and their families learn together with the help of this detailed feedback and stored EEG recordings. There's a broad spectrum of customizable options. So we can train our detectors on very specific features of the signal. We can also tailor how we give that stimulation, how much energy we give, over what period of time, exactly what frequency we deliver that energy at, the polarity of individual contexts. All of those things are broadly customizable. But that's related directly to the main disadvantage of the RNS system. One is that it requires a high degree of confidence about exactly where seizures are coming from. That's a little bit of a gray area, and we'll talk about that. But the other thing is that it's just an iterative learning approach. So it's not the kind of thing that you have this surgery, you plug it in, you turn it on, and everything is better the next day. It takes time. And in fact, sometimes it takes a long time to evaluate, to learn, to program, and to adjust so that we arrive at a place where we're clearly making things better, and making a good difference for the patients. Next steps with this. One is refining the location of stimulation. Where we started with this technology is treating it like something we can apply when we would otherwise do surgery, except that we're limited either by the potential for injury or other parameters. So we would implant it just where we thought seizures were coming from. There's growing evidence and active trials for using responsive neurostimulation to stimulate in the thalamus. We'll talk a little bit more about that with deep brain stimulation, which is aimed specifically at the thalamus. But there's potential there. Let's see. Sorry, I got out of order with my slides here. There's potential there to combine some of the strengths of RNS with the advantages of deep brain stimulation in the thalamus. We'll talk more about that. This is sort of, I like to provide, directly some of the evidence that we use when we talk about these technologies. So this is from a large multi-center follow-up trial of RNS implanted for treatment of focal epilepsy in different parts of the brain and outcomes. So one important takeaway from this chart is that it's showing multiple years of follow-up and outcomes, and it's divided by brain region. Neocortical means on the surface of the brain where the cortex has its typical 6-layer structure of cells. Temporal neocortical is especially important because the temporal lobe has the neocortical surface, which is sort of the outside, closer to the skull, and the mesial surface closer to the midline where the hippocampus is, which is a very common site of seizure onset for patients, and where seizures can behave differently. But the main takeaway here is that regardless of region, as time goes on, even over the period of like 6 years, the median change in seizure frequency improves. It continues to improve even 6 years after implant, right? So it's a little bit frustrating sometimes to have to deal with this as a patient because you have this stimulator implanted and it can take years for that benefit to accrue. The good news is that a lot of patients will have an improvement in the shorter term. It's just that as time goes on, that improvement continues to grow. That's a theme that will appear over and over again in the evidence we cite for neuromodulatory therapies. Okay, so let's talk about deep brain stimulation now. Deep brain stimulation is a technology that really came about probably about 25 years ago for the treatment of Parkinson's disease, and can be very, very effective in that context. So the technology, the methodologies have been around for a long time. It's very safe, it's very well tolerated, and it can be super helpful for treating the tremor in Parkinson's disease. There are other I guess I'll call them diseases, clinical entities that respond and that have been studied and that show benefit. One is depression, for example. Deep brain stimulation has been used for depression. It's been used for severe dystonia in patients with genetic reasons to have dystonia. And of course, also we're talking about it in the context of epilepsy. But the broad strokes are the same. There's a device, usually it's implanted just below the collarbone under the skin. And then a wire is tunneled under the skin up to where there is an entry point on each side of the skull, and then the electrical contacts actually go through the brain into the thalamus, which lives deep down near the midline on each side of the brain. The deep brain stimulator device is a little bit bigger, a little bit more bulky than the other two. So it's often palpable and sometimes visible in a thin patient in that area of the chest. The surgeon that we work with, Emily Levin, she's very thoughtful about where she puts the device. And if appearances, some people really care about, having a bump on their chest if they're in a bathing suit or something like that. So I've heard her have many discussions about, maybe we move it, closer to the armpit and we can hide it behind muscle or breast tissue, or especially in our younger children, we might implant that stimulator in their abdomen, in their abdominal cavity, and then revise it, into the chest as they get bigger. So the chest is the usual location. We're not totally married to that location. We can have a discussion if that's a concern, but it is a larger stimulator. It has a much bigger battery, and we'll talk about why that is. This is just a figure showing, this is actually what we think about a lot right now as clinicians, is exactly where in the thalamus should we implant these electrodes. Um, there are there are three main nuclei, and this is just collections of neurons that live in a specific region of the thalamus that have stronger connections to different regions of the brain. Um, Importantly, the area of the thalamus that was studied when it got FDA approval for epilepsy was the anterior nucleus of the thalamus. Um, so this is the area of the brain. It was studied in patients with focal epilepsy. It showed a good responder rate with minimal side effects and complications in the anterior nucleus of the thalamus, which has projections in what we call the limbic circuit of the brain, which is a very common area for focal seizures to arise. So this is temporal lobe, especially mesial temporal lobe, orbital frontal cortex, structures near the midline in the frontal lobe, something called the anterior cingulate, um, and then sometimes even insula, which is kind of a area of the brain surface that's sort of underneath some of the other lobes. Um, However, we have used and increasingly are using implants in the centromedian nucleus to treat generalized epilepsy. And the thinking there is that the centromedian nucleus has connectivity to the structures of the brain, sort of near the top, near the midline, where signals that go from one side of the brain to the other have to propagate. So they propagate very rapidly through something called the corpus callosum, which is like a very thick bundle of axons from all these neurons in the brain surface. Um, and the theory is that stimulation in the centromedian affects these areas involved with that bilateral synchrony and can be more effective when we're treating generalized epilepsy. And then the pulvinar nucleus, the picture is illustrative here. If the front of the brain is up here and the back of the brain is down here, the pulvinar nucleus is posteriorly located in the thalamus and has broad projections to the posterior regions of the cortical surface, the occipital and parietal lobes. And so if we have a patient with seizures that have onset in the parietal lobe or the occipital lobes, we'll definitely think harder about the pulvinar nucleus if we're thinking about thalamic neuromodulation. So there are important considerations here. We don't have fabulous evidence to drive these decisions. What we have is theory, knowledge about where these regions connect, and then reports by people who have collected patients and done these implants and said, yeah, we had decent outcomes, or we didn't have decent outcomes in these kinds of epilepsies with an implant in these locations. So it's very much an area of open study. As an example, and we'll talk more about this, centromedian nucleus for generalized epilepsy is something that NeuroPace, who manufactures the RNS device, is sponsoring a study to really collect good evidence that this is a good location for RNS to help decrease the burden of seizures in patients with generalized epilepsy. We talked about how with RNS we have data that's uploaded to the cloud that clinicians and patients can review to learn together. DBS, since I started doing this about 5 years ago in patients, the information we receive from DBS has improved. Right now, what we do is we're able in the clinic to use the device to measure what we call local field potentials in the thalamus where our contacts are located, and to try to understand what the frequencies are of those local field potentials and whether we're in the correct location and applying our stimulation in the correct location. This can be helpful, but it is certainly not long-term EEG data to help us understand exactly what seizures look like, what time of day they occur, whether our stimulation parameters directly affect or delay seizure onset. So it's helpful information, but it's not quite as in-depth or granular as the data provided by RNS. And importantly, it's only available to us when we perform a survey with the patient and us sitting in the same room in clinic. So it's not the kind of thing that's done automatically and stored to the cloud, um, which is, I think, a limitation of this technology. Um, but we do get some information. I think it's important to include that. One of the real advantages, and this picture, it's not shown here, but this picture prompts me to mention this, is that there are multiple manufacturers of deep brain stimulator devices. Uh, and the one I'm most familiar with is Medtronic, just because that's one we decided to use here at University of Michigan. But they have a handheld device that will sync up um, with the actual stimulator that patients can carry with them. It looks a lot like a little cell phone or an iPod Touch. And they can actually change. We can program in different stimulation modes for patients, and they can select among those modes. A lot of times what we do is we program an increase in the energy that we're delivering with therapy one day in clinic. We make sure that patients are tolerating that while we watch them in the clinic. But sometimes patients go home and they say, "Oh, I'm having side effects." A common one in the central median nucleus is patients might feel sort of tingling, pins and needles, or have some twitching of their face if we've gone too high. So that patients have the option of turning it back down without having to come back to clinic and see us and wait somewhere for us to come make those programming changes. We give them some flexibility for that, and sometimes that's very helpful. That's a really nice feature of the DBS system is patients can have quite a good degree of control. We can actually give them a range of different stimulation intensities that they can select from. Um, Another important feature of the DBS system is that very recently they came out with a rechargeable battery. So typical battery life for DBS is somewhere between 3 and 5 years. But if we're requiring very high settings and very frequent stimulation, sometimes that battery life can drop below 1 year. And in that case, it may be worth when the battery wears out, implanting a rechargeable device. What you do is you wear sort of a collar. It looks like a stole or something you wear at graduation that sort of sits around your neck and drapes over the device, and then it recharges wirelessly. And most patients recharge every couple of days for half an hour, and that keeps the battery nice and full, and it keeps things going, and they don't have to have the device replaced quite as often. That's something we've done with our patients. Um, so one of the big advantages here, of course, is that yes, we have to select among three primary locations in the thalamus, but that selection can be driven by what we know about where we think someone's seizures are coming from, and it doesn't require the intensive sort of repeat monitoring in the hospital. We don't have to catch a high number of seizures with electrodes inside the brain, which is a totally separate surgery. We can base our location recommendation on the results of a scalp EEG in most cases, and that creates a shortcut. We cut out all of this what we call phase two monitoring requirement. We don't have to work quite as hard to localize exactly where seizures are coming from. Which wrinkle, which gyrus in the brain has the seizure, because we know we're going to be stimulating the thalamus with its broad connections, to many areas of the cortex. The learning period where we have patients come in and we analyze and we adjust settings is shorter in general for DBS and RNS. There's less of this guess and check method, although it still exists. There's a number of months where we'll have patients come back and we'll make adjustments and get feedback from the patients about how they're doing. And I've already talked about how it does allow patients to have some control over stimulation parameters at home, which can be super helpful. It doesn't have as detailed a feedback. There are fewer customizable parameters, although we're learning how to apply more flexibly some of the parameters of stimulation. The next steps are really developing and refining the criteria, especially knowing exactly where to go, which of these three nuclei is the most important or most potentially helpful. Standardizing how feedback from the system is obtained and analyzed and used to customize therapy. And then, as with RNS, clarifying the use of DBS in generalized versus focal epilepsy. So there's work to do, there's research to do, but it can be a very effective and helpful treatment. This is the main figure from the foundational study that studied deep brain stimulation in the anterior nucleus of the thalamus for FDA approval for treatment in epilepsy. As with most of our studies, what we study here is uh, the percentage change in seizure frequency from baseline before the therapy was applied. Um, and with DBS, it's actually really nice the way they did the trial is they implanted everyone who enrolled. They just didn't turn it on, for the people who were randomized to be controls. So they had the surgery and eventually they had the option to turn it on. But our comparison here between active and control patients is a really good comparison because even the control patients had the surgery. And one of the things actually that you see here is that everyone had about a 20% reduction in surgery from or in seizures from the surgery alone, which is something we see across our modalities. There's something about manipulating the brain with this surgery that sometimes brings about a temporary reduction in seizures. But then the control patients, after 3 or 4 months, were really sort of approaching back to their baseline. Well, there's a distinct difference between active stimulated patients and control patients in this trial. So, you know, 3 or 4 months after implant, for the median, so the median patient had about a 40% decrease in their seizure frequency. VNS, vagal nerve stimulation, is a technology that's been around for quite a bit longer than the other two for the treatment of epilepsy. The important distinction here is that it's nothing is implanted inside the skull at all. So it's a similar looking device that goes underneath the collarbone, just beneath the collarbone under the skin. It's very low profile. It's about the size of a silver dollar and maybe as thick as 2 or 3 silver dollars. Um, so you sometimes can see a small linear scar from the implant from putting it in there, but you can't otherwise see it. You can feel it if you know what to feel for under the skin. Um, the wires, the electrodes are tunneled under the skin and wrapped around the vagus nerve. The vagus nerve is a large cranial nerve that originates from the brainstem, traverses through the neck, obviously, and is important in regulating the parasympathetic and sympathetic nervous systems. The discovery of use of VNS for treatment of epilepsy is a little bit of an accident. I don't pretend to be an expert on this, but I think what happened is, patients who had surgeries in their neck where the vagus nerve was manipulated, people started to notice that their seizure frequency went down. They were sort of protected from seizures temporarily. And so someone had the idea a long time ago, decades ago, to try stimulating the vagus nerve. And what we found is that, yes, in some patients, there's a really nice response to that stimulation. I forgot to mention this with DBS, but with DBS and VNS, our typical stimulation paradigm is programmed around what we call a duty cycle. So the device is on for some period of time and then it's off. It's not giving any energy for some period of time. A common profile might be on for 30 seconds and off for 5 minutes. But it's sort of does that all the time. So with VNS and DBS, you're not giving that stimulus in response to something that's happening in the brain. You're just giving it at arbitrary points in time. And you give a lot more time under stimulation than with RNS, right? If it's a typical duty cycle might be 10%, which means that it's on 10% of the day. So that's hours of stimulation over the course of a day in comparison to the minutes of stimulation over the course of a day with RNS. There's some debate, and it depends really on who you ask and what they're whether they're selling you a device or not, whether stimulation with this sort of open loop duty cycle model is more beneficial, or whether stimulation in response to abnormal brain waves is more beneficial. There are proponents of both. It's an open question that's actively being studied, and I don't have great evidence, to guide me or to guide my patients about which is better. but we'll learn that as time goes on. Um, the really nice thing about VNS is that if you have drug-resistant epilepsy, then you're a candidate, and it's very easy to schedule that visit with a neurosurgeon and to have the device placed. Um, and it can be very effective for some patients. So we short circuit all of this. We don't even need phase one monitoring. We don't need to capture seizures on EEG at all. If we're convinced that a patient's having seizures, um, and the first medication hasn't made the difference, then they're a candidate for VNS, and we can talk about it. The way we talk about this, and I'll show a graph here on the next slide, about a third of patients have an immediate and very substantial response to VNS, dramatic reduction in seizures. About a third of patients will have good response, but it may take some time. It may take months or even years to feel the full effect. And about a third of patients are really no better after implanting the VNS. It is important to mention that with VNS, because of its location and its features, getting MRI of the body after VNS implant can be very difficult. In fact, usually we just can't do an MRI, sort of between the upper and lower portions of someone's chest and abdomen, because the device would be in the magnetic field and it isn't approved for that application. So that can be important, for instance, for someone who has genetic or other reason to need screening for things like cancer. If it's very important to be able to get high resolution MRIs of their chest or abdomen, then VNS is probably something we would avoid because we're not able to get good MRIs. There's a subset of patients for whom it doesn't work, who subsequently say, I'd like to have the device taken out. Removing the stimulator battery is very easy. It's an outpatient, very quick procedure with a couple of stitches to close the skin. But the wire that's wrapped around the vagus nerve usually stays in place. It can get some scar tissue around the nerve, and it's more dangerous, more risky to take it off the nerve than just to leave it in place. Dr. Garton, who I've had discussions about this with, he's the neurosurgeon that I've discussed this with, has said, yeah, I think he has taken out VNS wires before in the context of an infection. But if they can avoid it, the neurosurgeons like to avoid taking the wire out. For some people, that's an important consideration. This device, once in, some portion of the hardware is likely to stay in forever. With VNS, the newer sort of iterations of the programming software and device have the ability to detect heart rate, and we can program that heart rate detection feature to increase the stimulation settings in response to a sharp increase in heart rate. We can even customize that to sharp increases in heart rate that only happen when the patient is laying down. The idea being that, patients who have a sharp increase in their heart rate while laying down, it's more likely to be due to a seizure, and the device can stimulate in response to that. It doesn't monitor brain waves. It's really not a closed loop system as far as brainwave monitoring and stimulation, but it can detect heart rate changes and provide additional stimulation. It also comes with a magnet that looks like kind of like a smartwatch or a bracelet that you can swipe over the device to kick it into a higher setting as well. So sometimes we use that as a rescue feature. It's not great for rescue for everyone, but for some patients it can shorten seizures. And I've had great success, for instance, with patients who may be at school or in a day program where it's hard to get to rescue medications, but it's very easy for caregivers to swipe the little magnet over their device in case of a seizure. So that can be an important and sort of helpful feature. This graph illustrates the responder rates in a couple of different ways for VNS. This is from a large meta-analysis, so a collection of many studies that have looked at outcomes after VNS implant. And this is what's called a probability density kernel. It's like a measure of a histogram, if you know what that is. And where it's taller, that means a greater proportion of patients fall into that bin, right? So, and the way to read this is that Gray is early, orange is 1 year, green is 2 years, and blue is at last follow-up, regardless of when that happens. But what you can see is that the 50% responder rate. So how many patients had a 50% reduction in their seizures? Within 6 months, about half of patients have a 50% reduction in their seizures. The farthest follow-up is green, and you can see that the median is closer to 60% in the group who has 2 years of follow-up after our VNS placement. So this illustrates the improvement over time. The other thing you can see is that there's a proportion of patients, right? The curves sort of dip down, but then come back up at the end. That's true here, that's true here, and that's true here. This is the proportion of patients who have a great response early. So this is a different graph. This is people who become seizure-free. That's a much lower proportion than the people who have a reduction in their seizures, but not become seizure-free. But you can see that similarly with time, we see that increases. So a proportion of patients will have a great response. About a third of patients will have a good response eventually, and a third of patients, sort of the area under this portion of the curve, they don't have as good of a response, and it's really hard for us to predict who's going to fall into which group. So that's important. It's an important consideration if you're thinking about this therapy. This slide is just an illustration of active clinical trials involving neuromodulation. It might be a few months out of date, but there are a lot of trials going on looking at different methods of neuromodulation in different populations of patients and trying to decide or understand who will benefit, how can we predict outcome, and where should we implant these tools to really help patients do better. I guess that's all of the sort of didactic information from slides that I wanted to talk about. I'm happy to answer questions if people have questions that they want to ask about this.
Thank you, Dr. Smith. That's great. And yeah, if people could, just for the purposes of the recording, keep their video off, but feel free to unmute yourself if you have a question. We have about 10 minutes left, so we're happy to answer any questions.
Yeah, I do have a question. So my child, aside from having epilepsy, has ESCS. They have normal brain spikes, I suppose. Mm-hmm. Regarding that, this RNS surgery, if done, does the anti-seizure medicine stop?
That's a great question. It's a super common question. The okay. Short and honest answer to that is usually not. Usually the patient will still be on anti-seizure medicine. But it's very common for the device to be helpful to the point that we can be on fewer medicines and lower doses of medicines. Our general practice is to leave medicines the same for at least 3 months after any surgery for treatment of epilepsy. The exceptions occur when someone is clearly having side effects and we need to get off medicines. The hope is that the device or the surgery is helpful and we can come off those meds that are causing side effects a little bit more quickly. But I would plan on if someone was to have a device implanted like this or a surgery, staying on medicine for at least 3 months, sometimes longer. And then we're very careful and deliberate about how we decrease to make sure that things don't get worse.
So here's a caveat. Here's a problem. Here's the rabbit hole that we're down. So we started her on Topamax and tried Keppra. We're on Amphi. And then I switched over to now U of M. And we did a Valium treatment with Dr. McNamara. And because she was anti-seizure free for 5 years. Mm-hmm. And then And then she started, I'm so sorry. And then she had her first seizure. And so now we're solely on Omphy. And then we were trying to do, I researched and I looked up Dimox. So we tried Dimox. It didn't really seem to lower her threshold because the last EEG, she was already at 100%. So my thought was, what's the point of keeping her on this if she's already at 100%? What's the point of keeping her on one more drug? Then she had another seizure. And so we are solely on Onfi right now, but at a much higher dosage. So it's only one medicine. So my thought would be if I did do this neurostimulology or responsive neurostimulology, would that have like an effect? Like, would that have a reaction to all of the stuff we've already tried that's already in her body?
Yeah, it's a good question. And unfortunately it's just really hard to predict exactly what things will look like in the future. Following general patterns, of course, which is sometimes the best we can do, and I understand that's frustrating. Your daughter will probably have some benefit from the RNS or DBS, and the hope would be we can come down a little bit on the medicines. But it's hard to know for sure. That's a really frustrating answer, I know.
Yeah, no, yeah. So, like, what would you suggest in our situation, knowing that what I just told you, like with all the procedures that you mentioned, what would be the best advisable route?
Yeah, it's hard to give super specific advice.
Right.
The
Sure.
the nice thing in your case is that Dr. McNamara is one of the most thoughtful and
Yeah.
sometimes creative epilepsy specialists I've ever talked to, and so I can guarantee she'll be thinking very hard about these questions and will give you good information. The advice I would give is to keep an open mind and to keep asking exactly the questions you're asking and saying, this is what's important to us. I wonder
Right.
about this. What advice can you give us? So,
Okay, fair enough.
yeah.
As a follow-up to that, Dr. Smith, have any of the three neuromodulation devices been studied specifically in terms of their impact on ESES?
Great question.
Very good question.
I'm not aware of any trials for these devices in ESES. I have seen them used for the treatment of ESES in situations where the medication options have been sort of all tried, and we're very convinced that someone is having bad effects because of all the spikes that happen in sleep, and we're trying something new to help decrease the spikes. I've seen it happen clinically, and we're keeping a close eye on how those patients do, but I'm not aware of studies. That's a great question, Russ.
Okay, other questions?
No.
Okay, I have another question. With RNS, there are 4 leads possible on the device. Only 2 can be active. Do you know, are there plans by NeuroPace to eventually make all 4 active? Seems like
Great
that would
question.
certainly help
Yeah.
provide more coverage and options.
Yes. So what I hear from representatives of the company is that yes, that's in the pipeline, but it's a ways down the road. It's at least a few years in the future. What tends to happen is refinements in the software algorithm, in the options we have, but changing the actual hardware parameters, I think, would require more FDA approvals, which is just a little bit more onerous. So I've heard that they plan to produce a device with 4 connections, but it's a few years down the road.
And I know in the interim, there have been instances, at least at some institutions, of implanting two separate RNS
Yes.
devices.
hmm
Is that something we've done here? Is that something we would consider? Are there disadvantages of that approach?
Great question. The main disadvantage is just having to undergo two surgeries and having two devices to manage upload and battery life on. It has definitely been done in other institutions. It's something we've talked about for a few of our patients. And I think the first patient to have that done will, at our institution, that surgery will be done in the next month or two. So it's something to think about if we really need that. And there are, epilepsy can do all sorts of strange and exotic things. And if the situation justifies it, it's something we definitely are open to considering and doing if needed.
Any other questions? Got about a minute or so left. Okay, well, I think we will go ahead and wrap it up. Thank you so much, Dr. Smith, for a very thorough and enlightening webinar, and thank you everyone for participating. Again, this will be uploaded to our YouTube channel and website so that people can go back and view it and share it with others as well. But again, really appreciate your time and expertise on this topic.
Thanks for letting me be here. It's great.
Thank you.